Okay, see if I can share that again. Okay, well, welcome everyone to another pediatric teaching. This week I wanted to go through what I went through last week because I felt like we rushed through some of it, and I wanted to do it as a sort of revision. Now, some people weren't able to attend last week, so it won't be revision. But I want to talk again about common forms of congenital heart disease, because it's really important that you get the fundamental concepts right, I think, in understanding heart failure and heart disease in children. So let's go through this again, and I want to spend a bit more time this week explaining a bit more about ECGs and what they can teach us about a child's heart disease. And we'll see if we can get through acyanotic congenital heart disease, because I'd like to get through that today, and then next week we'll talk about cyanotic congenital heart disease. But maybe first a bit of revision. I'd like to go back to the original concepts we talked about last week, and if anybody has any questions, or you feel that I'm going too fast, or you have questions, please just ask questions as we go through, if you want to. So I said last week that the signs of heart failure are very important to understand, and often we only understand heart failure as being tachycardia and hepatomegaly, and we don't always think about the types, what the clinical signs are telling us about the type of heart failure a child has. And I think we can do a bit better in terms of understanding the clinical signs and what they tell us about the type of heart failure. And so there are general signs. We all know that tachycardia and tachypnea are signs of heart failure, but then there are some signs that we see and observe and report that are signs of congestive right heart failure, such as hepatomegaly and generalized edema or lower limb edema, and a raised jugular venous pressure. They're all signs of congestive right heart failure. That means if the right heart's congested, as in not pumping strongly and not emptying well, then the central venous pressure will be higher, and that will lead to back pressure and congestion of the liver and edema, sometimes ascites, and a raised jugular venous pressure. And so they're signs of congestive right heart failure. They tell you something's wrong with the right side of the heart. And then there are signs of congestive left heart failure. So tachypnea and grunting are signs of congestive left heart failure, and fine crackles and signs of effusion are signs of left heart failure. Why? Because the left ventricular diastolic pressure is high, and that leads to increased pulmonary venous pressure, and that leads to pulmonary congestion. So they're signs of left heart failure. If the left heart's failing, the lungs get congested. If the right heart's failing, the rest of the body gets congested. And this is an important distinction to make. Often we actually see signs of both right and left heart failure, so biventricular failure. But I think it's important that we try to make a distinction between the two. I'll just admit a couple of people that Matilda's coming in. It's important that we try to make a distinction between the two, or explain the signs that we see. If you see a child who's got tachycardia and a very big liver and edema, then they've got signs of right heart failure. If you see a child who's got a big liver and crackles and edema and tachypnea and a pleural effusion, they've got signs of biventricular failure. Both ventricles are failing. And then there are signs that are not signs of congestive heart failure, but signs of low output heart failure, or low cardiac output. So hypotension, very weak pulses, the pulse volume is very low, a narrow pulse pressure, cold peripheries, and skin mottling. They're all signs of low output heart failure. And for some children, when they first get signs, develop signs of heart failure, they might only have they might just have hepatomegaly and tachycardia, but if it progresses, they'll have hepatomegaly and tachycardia and crackles in their lungs and tachypnea and grunting, and then if it progresses even further, they'll have low volume pulses and cold peripheries and skin mottling. And so they'll have all the signs. And so not only can the different signs tell us which part of the heart is most affected, the right side or the left side or both sides, but it can also tell us something about how severe the heart failure is, as in whether it's progressed to low output heart failure. And so I just want you to be able to make that distinction sometimes. And I said last week also, this is revision for those that missed last week, but I said that the causes of heart failure, an easy way to remember is you think about all the different parts of the heart. So there's the internal structure of the heart, and you can have a hole in the heart. And so that can lead to structural congenital heart disease, or the valves can be abnormal, and that could be either congenital, rarely, or rheumatic, much more commonly. So the muscle within the heart, or the valves, or the muscle in general. So you can have muscle inflammation, myocarditis or cardiomyopathy. A baby's born with an abnormal heart muscle, or a virus infection or some other infection leads to myocarditis. Rheumatic carditis can also be associated with the myocarditis as well. And then there can be a problem with the conduction system, such as supraventricular tachycardia. So that in most children that have supraventricular tachycardia, they have a structurally normal heart, their valves are normal, the muscle's normal. They just have an abnormality of their cardiac conduction system. And so that's another cause of heart failure. Then there's children that have problems with their pericardium. So they have a pericardial effusion, or they have tamponade, or if they've got TB pericarditis, they might have a constrictive pericarditis. And so if you think about the different problems causing heart failure, don't forget the pericardium, and it could either be a tamponade or constriction. And then there's heart failure secondary to lung disease, and that's quite common, isn't it? Because you've got children who've got acute pneumonia and secondary heart failure, or children with chronic lung disease, and they can have secondary heart failure, or children with pulmonary hypertension from whatever cause, and they will have right heart failure because of the pulmonary hypertension. And then there's probably less commonly, children with high output heart failure. So it's even though it's less common, there are many children, I'll just admit someone else, even though it's high output heart failure is less common, there are many children that have another cause of heart failure, and they become anemic, so their heart failure gets worse, and that may have signs of high output heart failure. But you always have to think, is there some other contributing factor to this child's heart failure, such as they become anemic? I think we don't recognize it, but there are a number of children that have thiamine deficiency if they've got severe malnutrition, and they have what's called beriberi, and they often have a high output heart failure. So they have a hyperdynamic circulation, and they may also have anemia as well. So I won't go through these other things, but if you remember, that can be structural heart disease, valvular heart disease, a muscle problem like myocarditis, a cardiac conduction problem, pericardial disease, heart failure secondary to lung failure or lung disease, and then high output heart failure. They're the main, if you think about it in that structured way, then you won't forget a different cause of heart failure. In terms of the structural heart disease, last week we talked a bit about cyanotic heart disease, and I wanted to cover that again this week. For those who've just joined us, I wanted to do some revision really on heart disease in general, and teach a bit more about how to read ECGs so that you'll be more expert in that, and just go over again the commonest causes of heart failure, particularly left to right shunts, so ventricular septal defects and PDA. Next week, if we get to it, we'll talk about cyanotic heart disease, so the different sort of heart disease. There are really two types of acyanotic heart disease, and that's either a large left to right shunt or left ventricular outflow tract obstruction, and we'll talk about this today as well, left ventricular outflow tract obstruction. All right. So last week I gave this case as an example. It's very common to see children who present like this with failure to thrive and recurrent wheezing, and if you ask the questions right, if you only think child's got failure to thrive and recurrent wheezing and tachypnea, you think they've got pneumonia or recurrent bronchiolitis, but you need to ask the right questions of the parents. And usually if the patient's got heart failure, then the story will be that when they feed, they can only feed for short periods of time, and then they become breathless, and they often sweat. And sometimes parents will even tell me that they can feel the baby's heart pumping beating very fast when the baby feeds. So just remember that difficulty feeding and sweating when feeding is a sign of heart problems. On the chest X-ray, you can see from this chest X-ray, we talked about this last week, how the heart is bigger and the lung fields look congested, don't they? They look plethoric, as in it looks like there's more blood in the lungs than what there usually is. Now, some people might look at this if you're not very experienced, and you might say, well, there's a bit of pulmonary consolidation, but in fact, you can see most of this is the pulmonary veins that are distended and congested. That's what it looks like. It looks symmetrical and congested lung fields with a big heart. If you examine this child, the pulses were hard to feel, and when you listen to the chest, there's lots of wheezes and crackles all throughout, and you would be mistaken for thinking the baby just had bad bronchiolitis, but because of this history of poor feeding and sweating when feeding, that's a clue to it being heart disease, and the X-ray gives a clue as well. So it's important that when we do see children who've got recurrent bronchiolitis, or as they seem to have recurrent pneumonia, or they come back in regularly, we need to just get some specific look for some specific signs of heart disease, such as, can the baby feed well, or do they become sweaty? Are they failing to thrive? How big is the heart? Do they have hepatomegaly or other signs of heart failure? The differential diagnosis, as I said, is broad, and it can be bronchiolitis, or in this case, it was a large ventricular septal defect. And I want you to know about VSDs because of all it's the most common significant congenital heart disease that leads to the heart failure in infancy. But also the babies with VSDs can often look like they've got recurrent pneumonia, and we need to make that distinction between that. We'll talk about PDAs a bit later, but let's just talk about VSDs. I said last week that they were one of the most common types of congenital heart diseases. So about a third, 30% of all congenital heart diseases are ventricular septal defects, and there's a number of different types of VSDs. Don't worry about the types, but typically these children present with failure to thrive and tachypnea and sweating when they feed. And on examination, they're tachycardic and tachypneic, and they have fine crackles on auscultation, and they have hepatomegaly. So they've got biventricular failure, haven't they? They've got both left ventricular failure and right ventricular failure. On auscultation, when you listen, there'll be a very large and often loud pansystolic murmur, and it's usually best heard at the lower left sternal edge. And if you run your stethoscope down the chest below the sternum, like into the subxiphoid process, then the murmur will still be heard. That's the marker that it's a VSD. If you do that and the murmur disappears, then it's probably not a VSD. It's probably something else. And if you run your stethoscope laterally across the chest to the apex, and you hear it even louder, and you can still hear it in the axilla, then it's probably not a VSD. It's probably mitral regurgitation. So of the types of conditions that lead to a pansystolic murmur, then a ventricular septal defect or mitral regurgitation are the two most likely. When you've got a VSD, just to explain the diagram, when you've got a VSD, it causes a left to right shunt because the blood preferentially flows from the left ventricle into the right ventricle and across the VSD. And so, as I said, this causes a left to right shunt. And it's the amount of blood that goes through the right ventricle and then through the lungs that dictates just how much there's pulmonary congestion. If there's a lot of blood going through the VSD, from the left ventricle to the right ventricle and out into the lungs, and then it comes back into the left side of the heart and then around again, then the child will often have quite severe pulmonary congestion, and they'll have an X-ray that looks like this with congested lung fields. It might even be worse. It might be much more severe pulmonary edema with a pleural effusion, for example. So some children who have large VSDs will have twice as much blood going through the right side of the heart as what they have going through the left side of the heart, and it's the increase in flow across the VSD that leads to pulmonary congestion and the symptoms. VSDs can be, it's important to know that VSDs can be actually very small, and they can get better completely by themselves. They can spontaneously resolve. And so a lot of the VSDs, they will resolve, but not if a child presents in early life in heart failure. Usually if the child presents in early life, in the first year of life, in the first 6 months of life with heart failure, then they've probably either got multiple VSDs or they've got a large VSD. If they've got a small, what we call mid-muscular VSD, which is just in the muscle of the, I'll just admit, Dorothy, it's the VSD being just in the muscle of the interventricular septum, a small VSD there, then sometimes that will just close over as the child grows and the defect becomes even smaller. But if they've got multiple VSDs, then they're less likely to close spontaneously. This is another chest X-ray, not the same one as I showed you before, but another chest X-ray of a child who's got a ventricular septal defect. And I just want you to be able to know what the cardiothoracic ratio is, and also to know what's normal, because what's normal in an adult is not quite what's normal in a child. And this you can see by looking at the heart looks big, but you can measure the cardiothoracic ratio. So it's the maximum diameter of the heart and the maximum diameter of the thorax. And in a child, it should be a normal is less than 0.6. So in an adult, it's less than 0.5. But in a child, especially in the first 2 years of life, you can have a cardiothoracic ratio, the cardiac over the thoracic diameter, to be less than 0.6, and that can be normal. But this was more than 0.6, and it's clearly abnormal with pulmonary congestion or pulmonary plethora. So it's telling you that the heart's big. But just remember, it's a bit different to adults where it's less than 0.5. Now, I wanted to spend a bit of time today talking about the ECG, and I'm going to focus a bit on ventricular septal defects, but I want to teach about how to read ECGs. And so I've added some more slides that I'll send around and you can have a look at them. But first of all, I think it's important, if we're going to learn about ECGs, to understand what the ECG actually means. And I want to try to make an ECG come alive to you, because when you read an ECG, you can tell things about the heart, the child's heart, that you couldn't just tell by clinical examination or by looking at the patient or looking at the X-ray. You can tell different things, but you have to understand what an ECG actually means. And so this diagram, maybe it doesn't explain it very well, but I want to try to explain about why an ECG looks like it does and what it actually is telling us. So I'm going to go through here the electrical conduction system of the heart. And the electrical impulses start at the sinoatrial node, which is in the right atrium. They then fan out to the atria, and you get from that a P wave or atrial depolarization, right? That means that you get atrial contraction. The atrial contraction equals the P wave, and that's atrial depolarization. The impulses fan out across the atrium and they reach the atrioventricular node, which is just in the just above the interventricular septum, right? It's at the base of the right atrium above the interventricular septum. This is the interventricular septum here, but it's above that. And so the time it takes to go from the SA node to the AV node is the PR interval, right? It's the start of the P wave to the start of the R wave. And that is the time it takes for the impulse to go from the sinoatrial node to the AV node. And so you can tell a lot about the heart just by looking at the ECG. And then what happens is the impulse goes from the AV node through the bundle of His, and then it divides into the right and the left bundle branches, right? And so the left, these innervate and depolarize the interventricular septum. And then subsequently, the left bundle branch depolarizes the whole of the left ventricle, and the right bundle branch depolarizes the whole of the right ventricle, okay? And so there's these other things called Purkinje fibers, which are simply just branches off the left and right bundle, the left and right bundles. And the time it takes for the impulse to get all the way around the ventricle is the duration of ventricular depolarization, which is the QRS complex, right? So this is the QRS complex, and this duration here, the QRS duration, is the time it takes for ventricular depolarization or ventricular contraction. Then there's the T wave, which is ventricular repolarization, which is just relaxation of the ventricle. And well, in that time, there's relaxation of the ventricle, and the impulse then resets so that the next impulse can come along. But the main things I wanted you to know are that the impulse starts at the SA node, it fans out across the atria, you get atrial contraction or atrial systole, and then the impulse is detected at the AV node, and then it branches out across the left and the right bundles into the Purkinje fibers, and you get ventricular depolarization, and then you get ventricular systole, that is contraction of the both ventricles, right? So, and while there's ventricular, I'll just admit some more people, but while there is ventricular systole, there is atrial diastole, that is the atria are relaxing, and while there is atrial systole, that is the atria are contracting, then the ventricle is relaxing. And so from the ECG, you can tell a lot about how long the cardiac impulse takes to get through the heart. And from that, you can tell a lot about what's wrong with the heart, right? As we go through some examples, I think this will become clearer. And all I want to do today is teach you about an easy way to read ECGs and to understand what they tell us, right? Now, when you're reading an ECG, you need to know that the y-axis, that is the axis up and down, is called amplitude, and it's just measured in millimeters. Whereas the x-axis along the bottom here, the x-axis is measured in time. It's also measured in millimeters, but you need to know that that there's a difference. There's time along the x-axis and amplitude along the y-axis. And I haven't written it here, but each large square is equal to 0.2 seconds. And each small square, there's 5 small squares for each large square. So each small square is equal to 0.04 seconds. These are fundamentals of understanding the ECG. So just remember that. So a small square is 0.04 seconds. A large square is 0.2 seconds. Okay. I hope that's clear for you, but I think you need to, if you understand the flow of conduction through the heart, it makes it much easier to understand how to read ECGs, right? So when you're reading an ECG, I only, maybe a cardiologist could do it in a more sophisticated way, but I just do it in a very basic way. And I think it's really, it helps me understand what's happening to my patients. So I read an ECG in a very systematic way. I read what the heart rate is, and that is 300 divided by the number of large squares between the RR intervals. So this distance here between the R and the R in large squares, 300 divided by that is the rate, all right? So I think most of you know this, but I'm just going to go through it in a systematic way so we don't miss out any of the steps. The next step is to know, the second step is to know what sort of rhythm the ECG is. And just to know that it is only sinus rhythm if there's a P wave before every QRS complex, and if there's an upright P wave in lead 1 and AVF. Right, so that the reason for that is that the P wave also has an axis, and the axis of the P wave should be between 0 and 90 degrees, right? And when you've got the axis between 0 and 90 degrees, then the P wave will be upright in lead 1 and AVF. If the P wave is not upright in 1 and AVF, then it still may be there's still an atrial impulse, but it might be coming from a different place than the sinoatrial node. Say if it was coming from over here, then the P wave wouldn't be upright in lead 1 and AVF. If the atrial impulse was coming from the left atrium, for example, then it wouldn't be upright in lead 1 and AVF. So it wouldn't be sinus rhythm, it'd be a rhythm coming from somewhere else in the atrium, right? I hope that makes sense. And if it's only sinus rhythm if three things are met. One, the P wave should be upright, should be before every QRS complex. Two, there should be an upright P wave in lead 1 and AVF. And three, the PR interval should be less than 0.16 squares. And sometimes as children get older, it can be up to 0.18 or even 0.2 small square, 0.2 seconds. All right. Remember, each small square equals 0.04 seconds. And so one small square is 0.04, two small squares is 0.08, three small squares is 0.12, four small squares is 0.16. And so in older children, it can be up to 0.18, so it can be 4.5 or 5 small squares, but not longer than that. So you just need to know what to determine whether it's sinus rhythm or not. You look at these three things, right? If the PR interval is longer than 0.16, then it's probably not sinus rhythm. It might be first degree heart block or second degree heart block. The next thing to do, so you've looked at the heart rate and the heart rhythm. The next thing is the P wave morphology, and morphology just means shape. The morphology is just the shape. And when you're looking at an ECG, then the normal shape should be a P wave that's no more than 2 millimeters high and a P wave that's no more than 2 millimeters wide, right? Easy to remember, 2 by 2, right? And if the P wave is higher than 2 millimeters, then that tells you that there's right atrial hypertrophy. Remember, the P wave indicates atrial contraction, all right? And so if the P wave is high, that tells you that there's a very thick heart muscle here, and the P wave will be elevated. If there's left atrial hypertrophy, then the P wave will be wider, and that's called P mitrale. But if you've got left atrial hypertrophy, then the P wave just takes longer to get through the heart muscle, so it'll be just longer, right? And so you need this concept of understanding the cardiac conduction pathways to understand what the abnormalities are, because the P wave is this part of the ECG. It's the atrial contraction. And if it takes a long time to get around the atria, then it'll be more prolonged, right? I hope that makes sense. If there's left atrial hypertrophy, then the width of it will be more than 2 millimeters or more than 0.08 seconds, all right? 2 millimeters being 2 times 0.04, which is 0.08 seconds. And sometimes the shape of it will look like an M because the P wave is going through the right atrium and then the left atrium, and it just takes that much longer to get through because of the hypertrophy of the left atrium. The next thing to look at is the QRS duration, the QRS duration. So we've talked about the P wave duration, but the QRS duration is very important too. This is the QRS duration between I'll just admit someone else, the start of the P wave and the end of the S wave, all right? And so at if there's a Q wave, then it's the start of the Q wave to the end of the S wave, all right? So the QRS duration, remember, it represents ventricular depolarization. And if you've got anything that delays ventricular depolarization, that is that if, for example, the ventricle was very hypertrophied or damaged, or the cardiac conduction fibers were damaged in some way, then there might be a prolonged QRS duration. I've got some ECGs of a child who actually had a damaged cardiac conduction pathway, and you'll be able to see how the QRS duration is prolonged. So normally it should be less than 2 small squares, the QRS duration, right? It should be less than 0.08 seconds. Remember, 1 small square is 0.04, so 2 small squares is 0.08. So the QRS duration should be less than 2 small squares. If it's more than 2 small squares, then either there's a bundle branch block, that is something delaying slowing down the impulse getting around the heart, right? Anything, any damage to the heart, a ventricular septal defect or anything like that can cause this to be slower going around the heart, right? It could be slow on the right side or slow on the left side or slow on both sides. And then the QRS duration will be more prolonged. It'll be, there'll be delayed conduction, right? So you can see by understanding the cardiac conduction, you can actually understand what's happening on the ECG. Then the next part, so you've looked at the QRS duration, and the next part is to look at the QRS axis. And I'll explain this in a bit more detail, but the simple way is to look at the net deflection in lead 1 and lead AVF. That's the way you should do it. And I'll show you a diagram of how to do it. I always draw a diagram and then just plot out the net deflection. And then lastly, you look for signs of ventricular hypertrophy. And I explained this last week, but for the left ventricle looks at the R wave in V5, right? And it looks at the S wave in V2. That's what the left ventricle is primarily looking at. The right ventricle, on the other hand, looks at the R wave in V2 and the S wave in V5. And so when you combine those two things, if the RV5 plus SV2 is greater than 35 millimeters, you just add them up, then that means there's left ventricular hypertrophy. And if the RV2 plus SV5 is greater than 35 millimeters, then you know there's right ventricular hypertrophy. And sometimes there's biventricular hypertrophy. Both ventricles are enlarged, and both of these will be greater than 35 millimeters when you add them up together. All right. Okay, that's just so. This is the ECG of a boy who had a very large VSD and ventricular septal defect. And what you can see from this, let's go through it perhaps. Let's go through it. So if you go 300, the rate, let's look at the rate, 300 divided by the number of large squares. So how many large squares are there in this ECG? There's about 1,
2.
2. Yeah, it's 2. You can see it actually here in V4. There's 2. So that's 300 divided by 2. So the rate in this child is 150. The next thing to look at is whether or not there is a is it sinus rhythm. So remember, what did I say to look at? Sinus rhythm.
The P wave before QRS complex.
That's right, a P wave before QRS complex. And what else?
Upright wave in V1 and AV.
Yes, is the P wave upright in V1 and AVS?
Yes.
It's upright in there, and it's upright in AVS.
Yes.
So therefore, the P wave axis must be between 0 and 90 degrees. So therefore, that is in sinus rhythm. And the third thing is whether or not the PR interval is less than 0.16. And so here we are. I'll just admit some people here. Here we are. The PR interval is 1, 2, maybe 2 and a little bit small squares, but it's certainly not more than 4, is it? You can see that the PR interval is actually quite short, somewhere between 2 and 3 millimeters. So somewhere between 2 and 3 millimeters in this ECG. So you know that the three things that tell you that this is sinus rhythm are fulfilled, aren't they? The P wave is upright in one and AVF. There's a P wave before each QRS complex, and the PR interval is less than 0.16 seconds. So that must be the ECGs in sinus rhythm. So we've got the rate is 150, the rhythm is sinus. The next thing we look at the P wave morphology, and remember that it should be 2 by 2 or no more than 2 by 2. So here we are, the P wave, it looks like it's about 1.5 wide and about one up. So there doesn't look to me, looking through it, if you can, anyone can see it, then let me know. But I think probably there's no, the P wave is within normal limits. It's no greater than 2 millimeters high, and it's no greater than 2 millimeters wide. So the P wave morphology is normal. Okay, so there's no evidence in this of right atrial or left atrial hypertrophy. The next thing is the QRS duration. Now just look at the QRS duration. Can you see the duration? It's probably a bit less than 2 small squares, isn't it? It's quite a narrow normal narrow QRS complex, right? It's not a widened QRS complex, it's a normal narrow QRS complex. And so that tells you that the QRS duration is normal, and that tells you that there's probably not any signs of a bundle branch block, because the duration is normal. There's sort of deep Q waves in these leads, but nonetheless the duration of the QRS complex is not wide, so probably there's not a bundle branch block. I'll show you an ECG in a moment that's got a bundle branch block, and you'll be able to see the difference. The next thing to look at is the QAS axis, and I said that I would show you that. Let's just look at the QAS axis. So here I've tried to draw what it looks like, and when I want you to look at the net deflection. So if you look, sorry, going back, this is just a normal, it's a vector diagram, and if you draw a vector diagram of the heart, then this is lead 1 looking out this way, and this is AVF. Remember, it goes towards the feet down this way, and this is positive and this is positive. All right, so a deflection that's positive in 1 will be out in this direction, and a deflection that's negative in 1 will be out in this direction, and a deflection that's positive in AVF will be down in this direction, and a deflection that's negative in AVF will be up here. Right? And so what you have to do is look at the net deflection of the QRS complex in lead 1. So let's look in lead 1. Here's lead 1, and the net deflection, is that positive or negative?
Negative.
Yes, good. It's negative. That's right, Ms. Burr. And for those who aren't familiar, what I mean by net deflection is that the QRS complex is this the RS pattern here, and you can see the R wave is relatively small and the S wave is quite deep. So the net deflection, that is the overall deflection from the isoelectric line, is negative. All right, and so what's the net deflection? How many what would you say the net deflection is? It's like maybe 4 millimeters up and maybe what, 6 millimeters down? Yeah, do you see that? 4 millimeters up, 6 millimeters down. So therefore the net deflection is what?
Minus 2.
Yeah, good, -2, that's right.
-2.
Yeah, the net deflection is -2 in lead 1. So let's go on and look at AVF. We've worked out the net deflection is -2 in lead 1 and the net deflection in AVF. What is the net deflection in AVF? This is AVF down here. This one. What's the net deflection? Is it positive or negative?
Positive.
It's positive, that's right. And it's positive. You can count the number of lead squares. So 5, 10, 15, 20. So it's counting the number of small squares, I'm sorry, but it's like 5, 10, 15, 20, maybe 21 up and maybe 5 down, you see? All right, and so the net deflection might be positive, say, I'm sorry? I'm sorry, say it again. It's okay. If you think that the net deflection in AVF is 5, 10, 15, 20, 21 millimeters up and maybe 4 or 5 down, then the net deflection is probably about plus 17, 16, 17. Yeah. So you've got a positive deflection in AVF and you've got a negative deflection in lead 1. So all you need to do is, drawing a vector like this, do the negative deflection of -2, and then proportionately, I just draw it out like this, count 17 down, let's say, positive 17, and then you know that the QRS axis is not between 0 and 90, but it's just beyond that, all right? And so all you do is draw a line, a straight down line from -2, and a straight across line from 17, positive 17 in AVF. And that's your vector, all right? That's the QRS axis. Now, I know it's going through a lot of things to find out the QRS axis, but once you've done it a few times, it's actually quite easy, and you'll get used to it as well. And it's important to know to be approximately right. You don't need to be, it doesn't need to be perfect, but you need to be approximately right. And so the QRS axis for this child is about 100 degrees. And if this was an adult, you'd say, well, that's quite abnormal. That it's called a right axis deviation. But for a child, up to the age of about 2 or 3, it's normal to have a QRS axis that's beyond 90 degrees. And the reason for that is because children, especially in the first few months of life, have higher pulmonary vascular resistance. And so therefore they have their right heart is more dominant than it is when you're an adult. Their left heart is still stronger, but their right heart is relatively a bit more dominant, all right? And so that's why you have a slight, what we call right axis deviation, but it's normal. So anything in the first couple of years of life, you can have an axis that's even up to 125 degrees, or even about 125 degrees, and it goes down as you get older. So normally, mostly we say for adults it's up to about 90 degrees, but can be even higher in the full range. Right. Okay. Now, and then the last thing is to look for biventricular hypertrophy or ventricular hypertrophy. And remember, I said that when you look at the R wave in V2 and the S wave in V5, and that tells you about what? If you're looking at V2, the R wave in V2 and the S wave in V5, what ventricle is that looking at?
Right side.
Yep, the right heart. Good. And so if you look at the R wave in V2, it's 5, 10, 15, maybe 16, 18, right? 18 up. And the S wave in V5, it's a bit hard to tell, but let's count this one. So 5, 10, 15, 20, 25. So 25 plus 18 is what? That's 25, 33, 43. So let's say the RV2 plus SV5 is 42 millimeters. And so what does that tell you?
Yes, right ventricular hypertrophy.
Yeah, good. Right ventricular hypertrophy. And at the same time, you can have both sides hypertrophy. So we should look at that R wave in V5. So where is that? Here we are. It probably finishes about there, doesn't it? About there. So 5, 10, 15, 20, 25, 20, 27 perhaps. And the S wave in V2, which is 5, 10, 15, 20, 20, 21. So 27 plus 21 probably leads to about 48 or 49. So what does that tell you? The R wave in V5 plus the S wave in V2. That's looking at the
Left ventricle.
left ventricle. And so therefore this child has left ventricular hypertrophy
And right.
and right. That's right. Left and right. So biventricular hypertrophy. That's right. And that's what you often get when you've got a large VSD, because there's a lot of blood going across the ventricular septum. And so the left ventricle has to do more work because it's got to pump more blood out the aorta. And the right ventricle has to do more work because it's got a large volume load. So you get biventricular hypertrophy with a large VSD typically. Okay, this is an ECG that I thought was useful to just show. Let's just go through this and we'll see if we can diagnose what's going on. So what's the rate here? Remember we said the rate was 300 divided by the number of large squares. All right, so I counted about 2.6 between the RR interval. So two large squares and maybe 0.6 of a large square. So 300 divided by 2.6 is about 115. So the heart rate is about 115. This is a 12-year-old boy. So the heart rate's about 115. What about the P wave? Is it sinus rhythm, I guess, is the next question. So is there a P wave before every QAS complex? If you look on the rhythm strip down the bottom, do you see a P wave before every QAS complex?
Yes.
It looks like it, doesn't it? It looks like there's a P wave before. This is the P wave here. This one here is the P wave. All right, the T wave is inverted. We won't talk about that, but it looks like there's a P wave before every QAS complex. All right, so that's the first criteria for sinus rhythm, is that there's a P wave before every QAS complex. The second criteria is what? There should be upright in lead 1 and lead AVF. And you can see that the P wave is upright in lead AVF and in lead 1.
Yeah.
And the third criteria was that the PR interval should be less than 0.16. And so here you've got 0.16 being 4 small squares. So we've got 1, 2, 3, 4. It looks to me like it's about 4 small squares. And this is a 12-year-old boy, so it's okay for it to be 0.16 seconds. So this looks like he at the moment he's in sinus rhythm. Okay. Now the next thing to look at is the morphology, isn't it? So let's look at the P wave morphology. What do you notice about the P wave morphology?
Its height is more.
Yes, that's right. Remember the 2 by 2 rule, and that is it's not more than 2. It's not more than 2 millimeters wide, but it is more than 2 millimeters high. It looks like it's at least 3 millimeters high. So that tells us that there's right atrial hypertrophy. Okay, so there must be right atrial. Yeah, right atrial hypertrophy. All right. Now, next thing, what should we look at? Perhaps the QRS duration. What about the QRS duration? Up here, you can see the duration quite well, I suppose. All right, so 1, 2, at least 3 millimeters. What was the, what does that tell you?
It's long.
It's long, isn't it?
Longer.
Yes, it's
In second.
longer than normal. So normally it should be 0.08 seconds or 2 small squares, but it's longer than that. And so what is that telling us? That if the QRS duration is too long,
There's a block.
there must be a block.
Conduction
Yes,
is taking longer to travel.
yes, that's right. Exactly. It must be that there's some slowing of the conduction around the heart, either a block or there's hypertrophy leading to the conduction just taking longer to get around, right? And so that's right. And this child, he's got a sign of a certain block. And remember what I said, what does V2 look at? What ventricle does lead 2 look at? V2 here, V2, 3, 4, 5. All right, so lead V2 is looking directly at what?
I think it's right.
The right ventricle, exactly, yes. It's looking at the right ventricle. So if you see that the QRS duration is prolonged in the right ventricular leads, like V2, and there's what's called an RSR pattern, then it's telling you that it's taking longer, the impulse is taking longer to get around the right ventricle. And so it tells you that there's a right bundle branch block. Remember I showed you that the diagram of the heart and how it divides after the bundle of His into left and right bundle branches. And if there's a block here, then there will be an RSR pattern in lead V2, because it's the right ventricle that sits at the front of the heart, and that's what the lead V2 sees. It's predominantly seeing the right ventricle. I'll just go to this one again. And so you can see there's an RSR pattern in lead V2. If the RSR pattern had been in lead 5, then it would have suggested that this is lead 5 here, and there's no RSR pattern. So it suggests that there's not a left bundle branch block, but there is a right bundle branch block, okay? And so that's the main thing that this ECG shows us. The heart rate's 115. It's in sinus rhythm, but there's a right bundle branch block or a delayed conduction through the right ventricle. And this child had he was in a motor vehicle accident, and he had trauma to his chest, and he got a severe bruising of his heart, and especially of his right ventricle. He had a severe injury to it, fractured sternum and bruising of his heart, and that gave him a right bundle branch block because it caused a disruption to the cardiac conduction pathways, and so there was a block in the way the fibers could move, the impulses could move around his right ventricle. That's a rare condition, but I thought it was just interesting to see what a right bundle branch block is. So again, going through it, his heart rate is 300 divided by the number of large squares, so it's 300 divided by 2.6, so it was 115. We said his rhythm was sinus rhythm. His P waves showed right atrial hypertrophy. His QRS duration and the right atrial hypertrophy and the QRS duration were both prolonged. So there's a problem with his right heart, both his right atrium and his right ventricle. He had severe bruising to his right atrium and his right ventricle. And his QAS axis, we didn't do his QAS axis, but what is the net deflection in lead 1? What's the net deflection?
Positive.
It's positive, and it's probably positive about 10. And in AVF, it's also positive, probably positive about 5, 10, 11 or something. Yeah, a little bit more. Yeah? So if you go back to the vector, then this is positive in lead 1. So you'd go out 10 here, and then it'd be say 10 or 11 down. And then if you draw a line down here and a line here, then the QAS axis is here. All right, about 45 degrees. And so therefore you know that this boy's QAS axis is at 45 degrees, so that's normal for his age. It's normal for someone like him. So the abnormalities on his ECG were primarily that he had a right bundle branch block, and he's got right atrial hypertrophy, but he's got a normal QAS axis, and he's in sinus rhythm. So you can actually tell a lot from the ECG that helps us understand what's going on in the heart. Even if we don't have fancy tests and things, you can read a lot into the ECG.
And Prof, is there a strain pattern on the V2, the inverted T wave? Does it mean that it's got a right ventricular strain pattern on the ECG?
Yeah. On V1, where you've got the inverted P. In V1 and V2, yeah, yeah, perhaps it does. I'm not quite sure. You mean the inverted T wave? You mean the inverted T wave? Yes, the inverted T wave. Yeah, yes, it does. It does actually. Yes, and in fact, this boy's complex. He had severe trauma to his heart, and he had a right ventricular and right atrial contusion, like severe bruising, and he also had a traumatic VSD, like the injury to his chest was so severe that he ruptured his ventricular septum, and that led to sort of ischemia of his heart. He's recovering very well now. He's taken a long time, a month to recover, but this is his ECG only from a few days ago, and it shows that he's still got the electrical abnormalities. Yes, he's got that strain pattern. Yeah. Okay. All right. So I don't want to go through. I don't want to.
Thank you.
Yeah. Thanks, Andre. Yeah. I don't want to dwell on that too much, but focus now back to VSDs, ventricular septal defects, and talk about the clinical things, clinical aspects. And I did mention, for those who weren't listening, weren't able to attend last week, I was talking about, well, why children with VSDs go into heart failure. And it's very important that we don't just accept they're going into heart failure because of the size of their VSD. Sometimes it can be other things as well. And we talked about how normally after birth, there's a fall in pulmonary vascular resistance. And that happens in the first 24 hours after birth. But then progressively, there's a drop in PVR, pulmonary vascular resistance, as the child gets older, like in the next few months. And that can lead to an increased flow across the ventricular septal defect. And that's why the child goes into heart failure, because of a progressively increased blood flow through the lungs. And things that can make it worse is if you are anemic. So if the child becomes anemic as well, then that can increase the amount of blood that's flowing through the ventricular septum. And something that can make it worse is also, I mentioned last week, and there were some questions about this, is if you give children with VSDs too much oxygen, then that can actually reduce their pulmonary vascular resistance, which you'd think would be a good thing, but it actually, in a child with a VSD, it may actually cause the shunt to increase and more blood to flow into the lungs. So it can actually worsen the child's heart failure. So it's just an important thing to note. In a child with a ventricular septal defect, you can give them oxygen, but you have to be very cautious about the amount you give so that you don't make their heart failure worse. Okay, the treatment for heart failure, these are the fundamental things you need to know. There's 3 types of treatment. There's in any sort of heart failure, whether it's heart failure from valvular heart disease or myocarditis or a large VSD, then you can give, there's afterload reduction, first of all, sorry, preload reduction, afterload reduction, and then drugs to increase contractility. And mostly we use drugs that lead to preload reduction. So diuretics lead to reduction in preload, which means the amount of blood coming back to the heart, and that reduces the amount of congestion that is in the lungs and is coming back to the heart. So it reduces, diuretics reduce salt and water retention. So when you've got heart failure, you're normally wanting to retain salt and water, and diuretics counteract that. All right. If you've got heart failure, you're not retaining salt and water in the normal way. You're trying to retain even more. And that's one of the reasons why you're trying to, the body tries to retain even more salt and water, and that leads to edema and heart failure. And so diuretics counteract that. The diuretics also reduce the preload on the heart. As I said, the venous return to the heart, and they reduce pulmonary congestion. And that's a good thing. It can reduce the crackles and the effusions in the lungs. And so diuretics are one type of treatment for heart failure. The second type is afterload reduction. So that means essentially vasodilatation, or reducing the systemic vascular resistance, so that there can be the ventricle can do a bit more work. All right, or it doesn't have to do as much work to pump the same amount of blood. And if you reduce the resistance under which the ventricle is contracting. And so afterload reduction involves using usually captopril or an angiotensin converting enzyme inhibitor, an ACE inhibitor, enalapril or captopril. Now that's useful in children with heart failure, but we just have to be careful about not using ACE inhibitors in children who have hypotension. And that's why we always should measure the blood pressure in children with heart failure, because you can it can either be quite safe to use captopril and enalapril, or it can be very dangerous, especially if the diastolic pressure is low. Right? Remember, the blood pressure is the systolic pressure over the diastolic pressure, and especially if the mean blood pressure or the diastolic pressure is low, then it can be dangerous to give ACE inhibitors. So if a child has a normal blood pressure or they're hypertensive, then ACE inhibitors are very good management for heart failure. But if the child's hypotensive, they've got low blood pressure, then it can be quite dangerous. Right? And then the third type of drug is drugs that increase contractility of the heart, such as digoxin. And digoxin, really, we used to use it a lot in children with heart failure, but probably it's not as useful as what we thought it was. There were some big studies done looking at use of digoxin in children with rheumatic heart disease, and really found that the only benefit was in children who had atrial fibrillation, which is quite common in rheumatic heart disease, but it's not. If the child doesn't have atrial fibrillation and they don't have marked tachycardia, then giving digoxin can lead to more complications. And so I usually just keep digoxin for children who've got marked tachycardia, like a rate of 180 or more, and you know that they'd be better if they had a slower rate, like 130 or 140, or if they're in atrial fibrillation for whatever reason. But typically it's children who've got rheumatic heart disease or in AF. But you need to check that first. You need to check if they're in AF, and you need to check whether their heart rate's fast enough. Don't just put them on digoxin. So I always use diuretics. I sometimes use afterload reduction if their blood pressure is normal or high, and I sometimes use digoxin if they've got AF or they've got marked tachycardia. Last week I just talked about the captopril and enalapril and how they work, and it's useful perhaps to know the renin angiotensin aldosterone system. And it's useful to know that because when a person's got heart failure, their renin angiotensin aldosterone system are really they're really working overtime, and you've got excessive amounts of renin and angiotensin and aldosterone circulating in the body. And so usually when there's low cardiac output or low blood pressure, then renin is secreted by the kidneys, and that gets converted into angiotensin 1 by angiotensinogen. So it's made in that converting enzyme, angiotensinogen, is made in the liver. And then there is angiotensin 1 is converted to angiotensin 2, and that's converted by ACE. This is the enzyme that is the target for ACE inhibitors, enalapril and captopril. And ACE, angiotensin converting enzyme, is made in the lung. And you remember that, if you remember that, this has become quite important in the last 18 months, is that ACE receptors, angiotensin converting enzyme receptors, are actually the receptors, as you might remember, for the coronavirus, for SARS-CoV-2, COVID-19. The angiotensin converting enzyme in receptors in the tissue of the lung is the way the virus gets into cells. And so most people wouldn't have known before that the ACE receptors are actually in the lung, but they are. Then angiotensin 1 gets converted to angiotensin 2, and angiotensin 2, it's important because it's a powerful vasoconstrictor. When you've got low blood pressure, usually the body responds by making much more angiotensin 2, and that leads to vasoconstriction, and often of all the blood vessels in the body, but particularly of the kidneys, and that leads to reduced urine output, and so therefore retention of fluid, and the blood pressure increases. And so the circular effect of this is that it starts with low blood pressure or low cardiac output, and then you get an increase in blood pressure because of angiotensin 2 and salt and water retention and vasoconstriction. And that might be a good thing up to a point, but after a while, that is a bad thing, because if your blood pressure increases, then the heart has to pump even more strongly against the higher resistance from the vasoconstriction, and then the heart goes into more and more heart failure. And so that's why ACE inhibitors can be useful, but they're only useful if you've got hypertension, right? Normal blood pressure or hypertension, then they can be useful, but you need to only give enough that you drop the blood pressure just a bit. You don't want to drop it too much, right? I can explain a bit more about that, but I just think it's useful to know how ACE inhibitors work and the renin-angiotensin-aldosterone system. Okay, I mentioned last week that the indications for surgery are essentially failure of medical therapy. So for some children that have really big VSDs, their heart failure won't be controlled by medical management, and they will continue to fail to thrive, even when you give diuretics and enalapril and maybe digoxin if they've got marked tachycardia. Even despite that and optimal feeding, some children remain in heart failure, and they'll require surgery. There's some other indications for surgery, pulmonary hypertension and other things, but it's mostly a large VSD in a child with uncontrolled heart failure where they're failing to thrive, and they keep coming back with recurrent pulmonary congestion. I mentioned last week about atrial septal defects, and I won't go through all of this. I'll send these slides around, but with an atrial septal defect, the main because the excessive blood is flowing across the atrial septum from the left atrium into the right atrium and then the right ventricle, then the left ventricle is generally preserved. Most of that is, it's not hypertrophied. Most of the hypertrophy is in the right side. You get a right ventricular hypertrophy or a right bundle branch block, and on the ECG, and the murmur sounds like an ejection systolic murmur, and the murmur is not because of the blood flowing across the ASD. The murmur is because of the excessive blood going out the pulmonary valve. So if you have a large ASD where the blood is flowing from the left atrium to the right atrium and then the right ventricle and then out the pulmonary artery, then you've got much more blood going out the pulmonary artery, and that gives you the murmur, all right? And it also leads to, because you've got more blood going out the pulmonary artery, then you have a delay in the closure of the pulmonary valve, and that leads to this, what we call a wide and fixed splitting of the pulmonary second sound. right? And so if you get used to listening to a lot of hearts, you'll be able to detect atrial septal defects, because you'll hear an ejection systolic murmur, just a murmur that sounds like whoosh, whoosh, and it'll be especially heard at the pulmonary area in the left upper parasternal edge, and you'll hear fixed splitting of the second heart sound if you listen carefully. Okay. In the ECG, sometimes there's a right bundle branch block, or right, like I showed you with the previous child. Remember, this is in lead V3 here, there's an RSR pattern. So RSR, it's not very convincing, but perhaps because of the enlarged right ventricle, there's the beginnings of a right bundle branch block. Even in V4, you can see that the QAS complex is a bit wider than normal, right? So these are the things to look out for in ECGs, because they can tell you a lot about what's going on with the ventricle or with the atrium. This child's atrium are normal, aren't they? You can see the P wave morphology is normal, less than 2 small squares up and less than 2 wide. So you know the right atrium and the left atrium are probably normal, but there's something going on in the ventricle, because especially the right ventricle, because there's an RSR pattern there. Okay. In understanding left to right shunts, you need to understand about VSDs and ASDs and PDAs, right? Because they all do the same thing. They all lead to excessive blood going from the left side of the heart to the right side of the heart. And a PDA, or a patent ductus arteriosus, it does it outside the heart, so from the aorta to the pulmonary arteries. And usually the ductus arteriosus goes from the arch of the aorta into the pulmonary artery, but of course that should close when excuse me. I'll just answer this, sorry. Okay. The babies who've got a PDA, you can tell because of their clinical features. And so if a child's got a big VSD, then often their pulses will be quite low volume, and sometimes they'll have those signs of low output heart failure, because most of the blood's going from the left side to the right side, and not much of it's going out the aorta. But if you've got a PDA, then the child will have a bounding pulses with often a very wide pulse pressure. And you can tell a PDA by feeling the pulses and by looking at the blood pressure. You know, often a newborn baby will have a blood pressure of, say, 55/18, like a preterm baby. And you can tell that that's a very wide pulse pressure with a low diastolic pressure. That's typical of a PDA. And the murmur isn't just a short systolic murmur, it's what's called a continuous murmur. So it sounds a bit like this. It's going through systole into diastole, and that's because the blood is flowing all the time through this PDA, going from the left side of the heart into the right side of the heart, going the aorta whoosh into the pulmonary artery, right, through systole into diastole. Sometimes PDAs close spontaneously, and sometimes they just need diuretics and fluid restriction, and sometimes they need prostaglandin inhibitors, because prostaglandins generally keep the duct open. But that's why we give indomethacin or ibuprofen. Whatever you've got will work, and it's usually pretty safe. And in about half the children, half the babies, indomethacin or ibuprofen will close the duct, and in the other half that it won't. Sometimes it's useful to give a second course of indomethacin, but after that, if it hasn't closed by 2 courses, then it won't close. Some people use paracetamol to close the duct as well, but but typically using non-steroidal anti-inflammatory drugs to begin with is what's used. The only risks of that are necrotizing enterocolitis and renal impairment. They're quite low risk. So if I've got a baby who's got a severe PDA and they're in heart failure, then I'd always use indomethacin or ibuprofen first. If that doesn't work, I'd use paracetamol next. And if that doesn't work, you know it won't close. So don't just keep giving indomethacin. You've got to realize that baby needs surgery. Okay, you can help the duct close sometimes by having the baby on diuretics and making sure they're not fluid overloaded, because if they're fluid overloaded, their duct won't close, and you can correct anemia in those babies, and that can also help the duct close. So having them fluid restricted can help the duct close, and then if that fails, then they need surgical closure. The last form of large left to right shunt I wanted to talk about, it's a combination of the things I've just mentioned, but an atrioventricular septal defect where you've got a hole in the atria and a hole in the ventricle, and sometimes that involves also the mitral valve and the tricuspid valve, and that's called a complete AV canal. And in those children, they present like a VSD, but they're often cyanosed because you've got mixing of blood within the ventricles, mixing of blue and red blood, so cyanotic, oxygenated and deoxygenated blood, and sometimes there's even sort of blood going in all directions because there's a problem with the mitral valve. You might get regurgitation of blood through the mitral valve as well. So these children with AVSDs usually present very early in life in heart failure, and they will have the pansystolic murmur of a VSD, and they'll also have often a pansystolic murmur of mitral regurgitation, and they'll have a systolic murmur of an atrial septal defect as well. And so they have lots of murmurs, and they're in heart failure early in life. So they typically go into heart failure in the first 2 months of life if you've got a large AVSD. And the chest X-ray just shows cardiomegaly and pulmonary plethora like with a VSD, and usually because the right ventricle is under so much pressure from getting so much blood, they have a right bundle branch block, and sometimes they have left axis deviation as well, because both their left ventricle and their right ventricle are under a lot of stress. And AVSDs do occur in children who don't have Down syndrome, but most commonly, most typically they occur in children who have Down syndrome. It's the most common congenital heart disease in children with Down syndrome, and the next most common is VSDs, and then tetralogy of Fallot. Okay. Now, finally today, I wanted to talk a bit about left ventricular outflow tract obstruction, because I said at the start the two things that cause acyanotic heart disease, like heart disease that's not cyanotic, are large left to right shunts, and the second one is left ventricular outflow tract obstruction. And I use these terms LVOTO, left ventricular outflow tract obstruction, because it explains a lot of different types of conditions. So it explains aortic stenosis or coarctation of the aorta, or hypoplastic left heart syndrome, and these are the causes of LVOTO, left ventricular outflow tract obstruction. And sometimes it's just involving the aortic valve, and sometimes it's involving the aorta itself, and sometimes it's involving the whole of the left heart, like the ventricle's small, the mitral valve small, and the aortic valve is small. And if you've got hypoplastic left heart syndrome, then it starts the hypoplasia is often involving the mitral valve, involving the ventricle, involving the aorta and the aortic valve, and all around the aorta. And so those children have very severe left ventricular outflow tract obstruction. And some children with coarctation can be very severe too, or it can be mild. And some children with aortic stenosis, it can be mild or it can be severe. Most of the aortic stenosis that you see is congenital. Sometimes children with rheumatic heart disease also can have some aortic stenosis, but usually they have aortic regurgitation instead of stenosis. So most aortic stenosis is congenital, but you need to recognize the signs of LVOTO, and they all present a bit in the same way, that they present with heart failure, usually in the neonatal period, and often it comes on very abruptly when the duct closes, because before the duct is closed, then no matter how obstructed the left ventricle is, then the legs, the lower limbs, and the lower half of the body is perfused with blood through the duct. But when the duct closes, if this is narrowed here, then the child will go into shock quickly. And so the child presents, usually they've been well at birth, but usually the baby's well at birth. You can't tell anything's wrong. And then the duct closes, the normal closure of the duct, and then the baby goes into shock. They're lethargic, they can't feed, they're pale and mottled and cyanosed. So they've got all the signs of forward flow heart failure, like low output failure. They're tachypneic and they've got cold limbs. Remember I said the worst type of heart failure is low output heart failure. So these children have that. They've got poor or absent femoral or lower limb pulses because they've got stenosis of their aortic valve or a coarctation. So you won't be able to feel their lower limb pulses, or they'll be very hard to feel. And they have a severe metabolic acidosis, usually a lactic acidosis. And because they have underperfusion of their kidneys with blood, then they go into kidney failure. So you need to recognize a neonate who has this problem, a neonate in shock, because they have all of these clinical signs. And if you see a baby like this, then there's only a few things that can cause a newborn baby who's well at the time of birth to go into shock. And it's useful to know the 4 things that can cause this in a newborn baby who's well at birth, not birth asphyxia, but the baby's well at birth. They usually go home with their mother and they're well for a few days, and then they go into shock. And it can be because of LVOTO, such as a coarctation or aortic stenosis when the duct closes, or it could be sepsis. These signs, baby can't feed, pale, mottled, cyanosed, tachypneic, cold limbs, they can all be signs of sepsis, can't they? And so sepsis is the second cause. And then there are some conditions where you have like an inborn error of metabolism that these babies also present in shock. And then sometimes if a baby's had like a sudden, like a SIDS, asphyxia at home, they might have had some episode of asphyxia, they can present in shock just like this, with lethargy, poor feeding, tachypnea, cold limbs. I suppose it's useful to always think that these babies might have sepsis and treat for sepsis, and but always think that they might have coarctation of their aorta or aortic stenosis, or even hypoplastic left heart syndrome as well. These other 2, asphyxia or metabolic disorders, are much less common. They're mostly when these babies present like this, well at birth, and then they become very sick. They've either got congenital heart disease or they've got severe sepsis. With these babies, it's important to do certain things in the first hour. And usually if you do these things, you can get them much more stable. And they need emergency treatment with oxygen. You need to put in an IV line, either some peripheral line or an umbilical line, give them some fluid resuscitation, give them antibiotics. I usually start them on adrenaline, and then do a proper examination to see that whether they've got a heart problem or not, or whether they've just got signs of sepsis, and then do some basic investigations. In the first hour after seeing a child, you can usually save their life if you do all of these things in the first hour: oxygen, intravenous fluids, sometimes a little bit of adrenaline. Okay, all right, so today we've talked about we've largely talked about large left to right shunts, and also left ventricular outflow tract obstruction, so acyanotic congenital heart disease. And I've tried to go over a bit more about ventricular, about the ECG and how to read ECGs. I think that's the thing I skipped over last week, and I wanted to go back and do it again, because I think if we can learn how to read ECGs, then we can learn a lot about understanding about heart disease in children. All right, I'm going to stop there and see if you've got any questions. If no questions, that's okay. So I've tried to cover this in this last 2 weeks, all about acyanotic heart disease and heart failure. And next week we'll talk about cyanotic heart disease, so that we will cover all cardiology in this couple of weeks. All right. Well, I hope that's useful to you, and I wish you all a very good week, and stay safe. And I'll see you next week. Bye now.
Thank you, Prof.
Thank you very much, Prof.
That's right. Bye now. See you. Bye for now.